I think we are
Yeah,
live.
we are live, madam.
Yeah, good evening, everyone. So, welcome all of you to the 75th Masterclass session. And I would like to congratulate Dr. Jay for being so passionate about teaching selflessly to everyone. And also, I think it takes immense energy and the dedication to do it uh, like this, like so back to back sessions, completing almost like most of the topics in fertility. And today the thing is like we will be talking about stimulation protocols in endometriosis by the king of endometriosis himself. So everybody knows he is a great endometriosis surgeon, and I think he's one of the best in India as of now. I have seen him operate quite a few of severe endometriosis with fertility related issues, and we have had extremely good results. Even this time, in my center itself, we had two positive cases of IVF after his clearance. But we would not be touching too much on surgical aspect today. We would be concentrating more on fertility aspect or stimulation protocols today. So the rest of the things like the other surgical part, I think has been covered in by Dr. Aarti in her sessions. So over to you, sir. You can start.
Yeah, so happy birthday, okay, Shilpa madam. And I will share the screen. So just see if the screen is visible, okay? Visible, no? Is the screen visible?
Yes.
Visible, right?
Yes, yes.
Okay. So see, whenever we are trying to talk of stimulation protocols, okay, in endometriosis, there are certain criteria, all right? So I will answer this in one line. Any protocol will work in endometriosis. Okay, any protocol will work. But if in case you want to really keep it cute, then you try to follow this flow chart, which I'm going to give you. All right. So whenever you want to do stimulation protocols for endometriosis, the first thing which you are supposed to do is you are supposed to do a detailed ultrasound. Okay. Now, in this ultrasound, basically, you are supposed to check two or three important things. Okay. So detailed ultrasound is a detailed pelvic ultrasound. Okay. Single ovary chocolate cyst. That is one. Second, both ovaries chocolate cyst. Okay. Third, deep endometriosis. So when I say of deep endometriosis, basically I am trying to look at nodules. All right. These are the three parameters which you should keep in mind when you want to stimulate somebody for endometriosis. Do not apply your head for anything more than this. Okay. Remember, whenever single ovary chocolate cyst is present, it's very, very simple. Is the cyst less than 4 centimeter? Is the cyst more than 4 centimeter? It is a single cyst. So that means the most important criteria of having a single cyst is opposite ovary is normal. All right. This single cyst can be adherent to the rectum, can be adherent to the uterus, cannot be adherent to the uterus. Both are absolutely fine. Okay. If the cyst is less than 4 centimeters, okay, just keep one simple rule in mind. Start stimulation. Okay, any protocol of your choice. If you like to use GnRH agonist, very good. If you like to use GnRH antagonist, very good. If you like to use random start protocol, very good. Because agonist is equal to antagonist is equal to random start is equal to dual stim. As far as endometriosis is concerned, I will touch upon dual stim a little more effectively because majority of the patients who are with bilateral endometriosis, that means bilateral ovaries chocolate cyst, so that means category 2 and category 3 are going to require dual stim. Okay. because they are also associated many times with a low AMH. All right. So this is one. Now, if the cyst is more than 4 centimeter, okay, what is important is that you should consider to drain and cystectomy. And after that, you should wait for 2 months or 1 month, okay, and then you should start your stimulation. Okay, this is important. Just remember this rule. I will justify everything in a little while to everyone. Okay, if both the ovaries are having chocolates, okay, then the rules are again very simple. No rocket science. Now, are they less than 3 centimeter or are they more than 3 centimeter? Okay, again, if they are less than 3 centimeter, then the answer is very simple. If it is less than 3 centimeter, you just start your stimulation. Okay, if they are more than 3 centimeters, again, it is very simple. You have to consider to drain and cystectomy, because first you drain, then you do the cystectomy. Okay, and wait for a month. And after you wait for a month, after that, you are going to start your stimulation. Okay, okay. Deep endometriosis, operate, then do stimulation. Absolutely no rocket science. Okay, very simple protocol. Now comes the question as to what you do in these cases. Okay, what do you do in anybody who is less than 3 centimeters and less than 4 centimeters? So you have done your stimulation, and do they require any surgery? Okay, so the answer is very simple. In this case and in this case, operate if there is pain after pickup. Okay, after OPU. So prior to embryo transfer, that is when you operate. All right, very simple rules. Do not confuse these rules at all. In the stimulation protocol, I would also like to touch upon one more aspect, which is again a very important aspect because people keep on asking this question. So I will draw and I will just explain. Now, see, there are many experts, who have only been doing egg pickups for endometriosis. They will tell you that even if it is a 25 centimeter endometriotic cyst, they want to do an egg pickup first. The rule is very simple. In an emergency situation, none of them are going to even pick up your phones. So just remember this diagram. This is your fallopian tubes. Obviously, you can't really see the fallopian tube unless there is a hydrosalpinx and you have your ovaries like this. All right. This is your vagina. Now, you may have an endometriotic cyst, which is a chocolate cyst, which is present here. Okay. Or you may have a large chocolate cyst, which is present here. Okay. Now, what is important is in endometriosis, actually, this ovary is going to be stuck inside the ovarian fossa. So, the rule which people try to teach us continuously is when you pass your egg pickup needle, ensure that the pickup needle does not really go through the endometrioma. So, avoid OPU needle through endometrioma. Go by the side. Okay, that is what people normally say. Right, it's not going to be very easy. It is going to be very easy if the endometriomas are less than 4 centimeters, but at size more than 4 centimeters, it is going to become extremely tough for you to do that. All right, that is one. Many a times people say that when the needle has by mistake entered the endometrioma, then you release the pedal. That means then you release the pedal of OPU suction. So what will happen is it will not cause an abscess. Now, this concept, whomsoever is classified and told, is an absolutely bullshit concept because ovarian abscess occurs when the needle passes from the vagina and enters there. So, the bacteria, irrespective of the suction, gets seeded from the vagina inside the endometriotic cyst. And as we were discussing, there is a bad complication called as ovarian abscess. I don't know how many of you have seen it in your life, but if you have seen it in your life, then you know one thing: you are going to have sleepless nights because the patient is going to require an antibiotic cover. And remember, 80% of these patients require surgery. and this is going to be a bad surgery. Okay. So on an average, every month as a referral unit for endometriosis, we would get two patients who would have obviously seen us before and we would have recommended surgery, but then the great people would be doing an egg pickup and they will end up with an ovarian abscess, which will end up in a sepsis, which will be then referred to the ICU, to surgical ICU, and then they will end up with oophorectomy. Okay. So if you have not seen an ovarian abscess, then do not attempt the gamble of not following the protocol which we just showed. Okay, cyst more than 4 centimeters, more than 3 centimeters, kindly go and operate. Do not attempt to use your head. It is a very, very standardized thing. So I know one thing, lot of people who practice deep endometriosis or, try to practice, they would at least say one thing that no, there is, ASHRAE guidelines have come up and ASHRAE guidelines have told this and that and all these things. And somebody will tell you can give 24 months of Dynogest, you can give 25 Lupride Depot, all these things. Please remember one thing. Once you do a radical excision of endometriosis, okay, radical excision of endometriosis. Now, radical excision of endometriosis also includes something called as peritonectomy. And remember, in this case, once you do radical excision of endometriosis with peritonectomy, definitely AMH will go down. There is no question because you would have done cystectomy. Okay, so the AMH would go down, but your oocyte quality will go up drastically. Okay, your embryo quality will go up drastically. Okay, and your results will improve. This, I don't know what's the mechanism, but this is something which is a take home point in any case where you have to attempt surgery. So now when I say attempt a surgery, this surgery has to be attempted by somebody who knows how to operate on endometriosis, not by people who usually claim to know on how to operate on endometriosis, because these are extensive surgeries. And as we have shown probably 200 times on our Facebook live surgeries, that you need to go and you need to do a complete clearance. Okay. Initially, you will feel bad about this because your AMH value will drop. But if in case you have encountered patients where you have never formed embryos, if in case you have encountered patients where egg quality was poor, okay, that is a very, very, very important indication of going and doing a surgery and then repeat stimulating the patient. Trust my word on this. If you repeat stimulate the patient directly without doing the surgery, your egg quality, embryo quality, and blastolation rates are not going to improve. But the minute you take out the peritoneum, the minute you do an operation for cystectomy or deep endometriosis or whatever, as I mentioned, AMH will go down or may go down, but the other embryological parameters will go up drastically well. Okay, and I think I have huge workload of endometriosis. So we end up doing a lot of patients who end up conceiving naturally after these surgeries, and a lot of patients who require IVF and they conceive extremely nicely. Okay, so this is just something which I wanted to share with everyone. Remember, there is no protocol which is better than the other protocol. Okay, agonist protocol is not better than the antagonist protocol in endometriosis. Antagonist is not better than random start. Random start is not better than double stimulation. You will not require to use an increasing dosages of HMG or recombinant FSH in endometriosis patients. Your dosages are going to be absolutely the same like any other patient. What is our standardization? We have told you many times. We standardize it at 300. We don't give baby ecosprin dosages 75, 112.5, all that we don't give in endometriosis. Start with 300. Okay. Something which is very good, which you must incorporate in practice is pre-treatment antagonist. See, endometriosis is one thing where because of this low AMH and presence of endometriosis, there will be asymmetry in antral follicle count. And this asymmetry in antral follicle count on day 2, day 3 is extremely common in endometriosis patients, both non-operated as well as operated patients. Understanding? So pre-treatment antagonist in our protocol is an absolute standard. for endometriosis patients, we don't even think twice. We give pre-treatment antagonist. Okay. One special situation will happen, and you will encounter this many times, is when you started stimulating endometriosis patients, suddenly after 6 days, 7 days, you will find there is no response. Okay. You will think that, 5 dosages have gone, but I saw 6 antral follicles and now I am seeing only 2 dominant follicles. That is an indication to go ahead and operate the patient. Okay. That poor response is due to the presence of peritoneal factors or due to the presence of that endometriotic cyst and the altered chemokines which are generated out of it. If at all you face that situation, kindly go ahead and operate that patient. Do not continue stimulation. It will be an iatrogenic poor response to that particular patient. And finally, before I conclude and start answering questions, I want to tell you one important thing. If you have more than 2 episodes of localized unruptured follicles, the first thing that should come in your mind is peritoneal endometriosis or endometriosis in our situation. Okay. Do not change your protocols. Just think of endometriosis, put a laparoscope, rule out endometriosis, see if there is endometriosis, treat that endometriosis. Okay. And only then go ahead with the stimulation. Okay. And one final thing. Sorry, but one more important thing. See, if in a patient, so we do it standardly, and I'm just sharing it with all of you. If in any of the patient of endometriosis, if CA125 values are more than 50, okay, strongly suspect peritoneal endometriosis. Okay, strongly suspect it. Even if you say, oh, ovary is having only 1 centimeter cyst, no problem. Suspect peritoneal endometriosis. Trust my word. I know many people are so expert that they will not believe me at all. But if you remove that peritoneum, okay, in that situation, the outcomes of the patient are going to be excellent after that. Okay, especially embryo development, blastulation rates, and implantation rates. Okay, of course, I have not published this, so people can say he has no experience any which ways. But I think we would have had achieved more than 200 pregnancies so far in our career, at least over the last 4 to 5 years, for patients who have never formed embryos in the past. Okay, CA125 was raised, and we have only done peritonectomy. Okay, so with this, I conclude and I will answer questions from Shilpa madam.
Yeah. What about the trigger? I mean, do you change your trigger just it is endometriosis?
Nothing, just give double trigger. If you don't understand anything, give both.
Yeah. So, what are the difficulties in OPU post-surgery? Like post-surgery, you have stimulated a patient and you have scheduled the OPU. Do you
There is only one problem. See, if I am operated, you know how I am operating, right? Because I always keep that fertility aspect in mind, but I also try to hitch many a times ovaries to the round ligament. So the only difficulty you will experience is ovary will be slightly higher up. That's it. Okay. Apart from that, no problem.
Yeah. So can you schedule the laparoscopic oocyte pickup along with cystectomy in the same sitting?
No, it will cause an abscess.
Why? No,
Because
as
what
in
will
laparoscopically, no, you're doing.
Yeah, still, madam, because you will end up perforating, puncturing that, and chocolate material will start coming out. Okay, and there will be seeding which will occurring from one part of the peritoneum inside that endometriotic cyst. What will happen is that ovary will be so vascular that at that point in time you will not be able to do a cystectomy also. It will just be a drainage, and that too an incomplete drainage. So you should never do that.
Okay. And when do we start the stimulation post-surgery? So usually
Next month,
AMH will drop.
forget that. Next month.
I think this is a very important point where there should not be given much gap between the.
No break.
Yes.
Next month. Simple.
Even though we don't see many follicles the next month where ovaries
No problem. You will still get excellent oocytes.
Yes. So this has been my personal experience also that if we stimulate them immediately, then the chance of conceptions are much better. And especially if the tubes are okay and if you have done the surgery where you have enhanced
The
the
next month do IUI. If tubes are open, do IUI from the next month. No wasting time.
and so if the ovaries are adherent, okay, so in during surgery, I mean, just keeping in mind that, like, the fertility aspect, so always adhesiolysis is important, right? I mean, bringing the ovary into the ovarian fossa, like in the normal anatomical place. I mean, is it mandatory?
Okay. Please understand. The normal position of the ovary is not adherent to the ovarian fossa.
Yeah.
The normal ovary is a free hanging structure in the pelvic cavity. Okay. What typically happens in endometriosis, it goes and gets stuck to the peritoneum, which is lateral to the uterosacral on both the sides, which is called as the ovarian fossa. Okay. In order for ovary to get released and go on up, okay, where it is at its normal position, you will have to do peritonectomy and get that ovary back to that place. Okay.
Yeah. Uh, so what is the role of letrozole? Say letrozole, because endometriosis is estrogenic inflammation.
Yeah.
So letrozole during stimulation along with HMG or REC-FSH.
Yeah.
I believe in this protocol in endometriosis especially.
So, I mean, you know our protocols. Like we will add letrozole to more than 80% of the cases. We really don't hesitate in adding letrozole in any of these protocols.
So what is the role of letrozole with regestrone prior to transfer in endometriosis? I'm not talking about adenomyosis, in
Hmm.
endometriosis.
Okay, very important question I think you have asked. Letrozole plus registone only and only has a role if a patient has diffuse, the word diffuse is very important, diffuse adenomyosis, where the maximum uterine length is less than 10 centimeter. Okay. In any other case, so that means if you have a focal adenomyosis, letrozole plus registone has no role. If you have deep endometriosis, letrozole plus registone has no role. If you have a chocolate cyst, letrozole plus registone has no role. Okay. None of these hormones have a role. Letrozole plus registone only helps in diffuse adenomyosis. No other indication.
And for improvement of the endometrial receptivity, do you suggest adding any supplements in endometriosis cases like post surgery?
So, endometrial receptivity in endometriosis is a beautiful topic. I think we can take two master classes on it. One must remember is that the amount of cytokines which are released due to the presence of endometriosis in the pelvis, they alter the flow of blood in the uterus. Okay. So if in case you want to do something good to endometrial receptivity, go and operate that endometriosis. Take it out, make it a radical surgery, and then do your embryo transfer.
Yeah. So I think that's a good point, I believe. So the inflammation in endometriosis, it kind of modulates the immunity also. So do you
Yeah.
suggest an immunomodulator in that?
Immunomodulators, I think so. I am very bad at publishing papers, but the first paper which I am going to publish in my entire life is going to be how thymosin helps in deep endometriosis for fertility preserving surgeries. So now we have utilized almost 1750 vials of thymosin alpha for endometriosis patients. Okay. And the data says that the improvement in implantation compared to our past data, where we never had used thymosin alpha, okay, has shown an incremental UPT positive rate as well as clinical pregnancy rate as well as till cardiac activity by 12%. Okay. But the bias is either I have become a better doctor or a better embryologist or thymosin has worked. We don't know that. Honestly, because the data so far post radical excision of endometriosis where we have conserved for the fertility is only 32 patients, which we have, madam. So I mean, think some journal, if we give some bribe, it will publish, but I don't know how much it will work. Okay, but it is experimental, honestly.
Okay. And give a straightforward answer for this. No, this thing. So, giving diagnosis prior to embryo transfer after you have
Yeah,
done surgery, does it really improve the success rate? I mean, just answer it straightforward. Okay. No
no,
abuse anything.
no, straightforward.
Uh,
I
that
answered no.
Oh, okay, sorry. So cumulative pregnancy rate in your experience, since you run like, a tertiary, almost like a quaternary IVF center where like all failed cases and all cases where embryos not forming or endometriosis and all such things you tend to cater to. In your set of patients, do you think the cumulative pregnancy rates in endometriosis, like even post surgery, is it reduced
Uh,
with IVF?
see, yeah, see, for any endometriosis, let's assume you are giving a 35% live birth rate, at the end of the year. If you are dealing with deep endometriosis, it will go down by 5 to 7%. That is
Mm,
a no-brainer, man. You know,
mm.
so that is something which has to be counsel to the patient, 100%. So we do it. We have seen us doing it in Bangalore also, right? So
Okay, tell about this prolonged pituitary suppression with GnRH analogs prior to transfer, like giving depot. Will it really help in implantation? Will it really suppress the microscopic disease, which is not taken care by surgical aspect?
no, it is good in diffuse adenomyosis. Just like how letrozole plus regestrone helps, it is
Mm.
good in that, madam. But it has got no role whenever there is a nodular endometriosis.
Okay. And is there any difficulty in doing an embryo transfer in cases of these nodular lesions, endometriosis, or like, deep endometriosis? Do you find that doing an embryo transfer is difficult?
You want a Jay Mehta answer or a scientific answer?
It's okay, whatever.
Okay. See, uh, if somebody is going to tell that it is retroverted uterus, that is why embryo transfer is difficult, okay, then it is a proper, beautiful theory answer. I don't think that should be considered only. What should be considered is in presence of nodular endometriosis. The big problem is abnormal uterine contractions. Okay. So in this abnormal uterine contractions, even if you do the best embryo transfer, the success rate for implantation goes down drastically because uterine contractions would cause spasm in the arterioles, which causes temporary hypoxia, which reduces implantation. So just in case you want implantation to occur and you are an hardcore infertility specialist who doesn't touch endometriosis, talent is available in India in abundance. Okay. Arrange a workshop, keep all these patients, call a good endometriosis surgeon to operate all of them for free and do embryo transfer in the next month. Okay. They will all conceive because the nodular endometriosis would have been released. Uterine contractions would go down by probably 80-90%. Uterine anatomy will be restored. Embryo transfers would be easy and your patients will have a better outcome.
But what about using atosiban and buscopan, things like that, like, which can relax the uterus?
See, really, if atosiban was so good, no, then by now Abbott or somebody would have launched their own atosiban. Please understand. Okay. So atosiban, in my opinion, at the moment, at the time of embryo transfer, okay, is a little bit of a gamble, is what I think. Okay.
Mm.
It has got no proven role, no proven benefit, nothing.
Yeah. Yeah. So what do you think, I mean, medical management in endometriosis, especially for patients with IVF? I mean, where is that one indication where you would give them medical management?
See, in sizes which are less than 3 and 4 centimeters, which I mentioned, the
Mm.
great thing is they don't need medical management.
Yeah.
You can stimulate them directly.
Mm.
In sizes which are more than that, the great thing is they don't need medical management again, because medical management will not work.
Yeah.
Okay. So basically, medical management, just like how it has got no role, it has got no role in IVF also. Okay.
Yeah. So, do you think, like, the response of IVF post-surgery, it's the best in the immediate cycle, or you would like to give an OC pill and then stimulate them after down-regulating them and all that? I mean, do you go through all these things?
No, madam. We stimulate them immediately.
Mm-hmm. Yeah, I think this was a very, very good session. I think a lot of questions have been answered. I think it will be easier for us to, for me especially, to answer people to just say that watch this class, because I think we have covered most of the controversial things, especially on unilateral cyst and bilateral cyst and deep endometriosis. So it was wonderful. Thank you. It shows that you have so much experience in treating them laparoscopically and also following it up with IVF. So thank you. It was great.
No, no, wait. I think I just want to tell 2, 3 more things.
Mm,
In endometriosis, when you are doing embryo transfer, okay, if you have not operated the patient,
mm,
don't attempt to do a modified natural cycle. Don't attempt to do a natural cycle transfer. Okay. What will happen in this natural cycle transfer or a modified natural cycle transfer is that the rupture will not be very spontaneous and nice. If the rupture is not spontaneous and nice and corpus luteum is not formed correctly, your entire MNC cycle will have an out of phase endometrium. Okay. So if you have not operated the patient, don't attempt a natural cycle or a modified natural cycle. Better to go with HRT protocol. Okay. If you have operated the patient, all right, then as we told, because the AMH value has gone down, then also don't attempt a modified natural cycle or a natural cycle. In that situation, also it is better to go for HRT cycle. So HRT cycle should be the standard of care as far as endometriosis embryo transfers are concerned. Okay. No additional or major requirements of any form of progesterone. Standard vaginal progesterone gel is equally good. No requirement for any add-on factors. No sildenafil, fildenafil, arginitric, this nitric, that nitric. Nothing is required. No heparin is required. We don't give heparin. We were giving, but we realized after our retrospective analysis that we made a mistake in giving it, honestly. And we apologized to all those patients, okay, that we had to give them heparin at the time of embryo transfers. It's a painful thing, so we've stopped giving heparin also since the last 2 years to all these patients. It doesn't work at all. Just do a nice endometrium, nice surgery, and patients become pregnant. Just keep that in.
yeah, these were
Okay.
good points. It was excellent. Good, good, good. Thanks. Thanks. It was wonderful.